Hello, everyone, and welcome to Henry Schein's series on COVID-19 on YouTube. I'm Dr. Gary Severance, and it's always my pleasure to welcome Dr. David Reznik. Today, he's going to share a little bit about what's going on with COVID-19. It's still hanging around, the latest CDC guidelines, and whatever happened to monkeypox. Dr. Reznik, welcome.
And good day, everyone. As always, it is a pleasure to be able to give you the latest update on COVID-19 in dentistry. This is more of an Oktoberfest kind of month. We're seeing some good information as opposed to a scary Halloween. So things are, for the most part, are looking good. Is this the calm before the storm? We really don't know, but we're going to go over some of the things that are happening as far as maybe some changes to CDC guidelines. We are going to look at long COVID because some of the people are developing diabetes, which could directly impact the care that we provide. And I really do have to thank Dr. Severance for mentioning to me, why don't we update where we are with monkeypox? And so there's been some interesting news about a case of occupational transmission. But also how well when people do things to protect themselves, get vaccinated, and how we can get what looked to be a really serious thing that was blowing out of control. And just to give you a little heads up, we're already at an 85% reduction in cases. So it really is how we try to protect ourselves. And we're getting ready to go into the flu season. So it's time to get our flu shots. If you are of age, it's time to get your bivalent booster. I'll be honest, I haven't gotten mine yet, but I plan on getting it before the weekend. And yes, I'm going to get flu and the booster at the same time. There's no interaction, so just so you know, it's safe. But I do want to thank Dr. Severance for helping me bring monkeypox into today's presentation, because I think it has some lessons for all of us on how we're going to be managing COVID in the future. Are we at an endemic level at this point? I mean, it's something that's going to be around. And that might be the case for someone who's in their 30s, but it still is having negative impacts for our elders. And that's very important that we protect our families, our patients, and our staff. So our levels are declining, and that is wonderful. The number of cases we're seeing are declining. Incredible news. But we do have some subvariants that are rising. That are coming from new lineages. And so BA5, which is what really was dominant for a period of time, I'm actually going to show you a graph in a little bit that shows it's starting to lose its dominance, and it's coming down to about 67% of what we're seeing. And global developments, and that's important because whatever we see happening in Europe is sort of a predecessor to what we're going to see in the United States. So there is a steady rise, not a jump, but there's a steady rise in cases in Europe, and it's the biggest impact, again, is on seniors. In the weekly review, CDC said the 7-day average for new cases decreased 12%. Incredible news when compared to the previous week, with the country averaging still about 39,000 cases a day. So it's not gone, it's not over, but we've been able to do things that we really have wanted to do and not been able to do for a few years. Let's enjoy the break we have, enjoy the beautiful fall weather, although I don't know what's happened because Atlanta is freezing, and that is not normal for this time of year. But enjoy the weather, get together with family and friends, but also get yourself protected before the holidays come up. And I think that's really when we're with our family, with the elders in our family, we want to make sure that we stay happy and healthy. The 7-day average for new COVID hospitalizations has also decreased. For those who have been watching these presentations, I would show the Grady graph on how our hospital was being overrun with COVID patients. It's a small percentage of our hospitalizations right now. So that's actually good. Deaths are declining, with the 7-day average of new daily COVID deaths down 8.5%. but we still are averaging 328 COVID-related deaths a day, making it in the top 5 causes of death in the United States. Actually, we have seen a reduction in the expected life expectancy due to COVID by a couple of years. So it's had that significant impact on our children. It's had that significant impact on our colleagues, our friends, and possibly some family members. The percentage of counties that have a high community COVID level have declined slightly, and the number with medium community levels showed a moderate decrease, while counties with low community levels increased moderately. So basically, we're actually seeing some good information. More than almost 15 million Americans have received their updated bivalent booster, but the CDC emphasized that nearly half of the eligible population have not received any boosters yet. And so we get some natural immunity. That is important if you've had it, but it doesn't last forever. And I'm going to contradict something that came out of our federal government. Yes, getting this booster is great, but it's not going to protect you for an entire year. We haven't seen any mRNA vaccines that last for an entire year, so we'll have to see how things develop. And maybe we won't need a booster because maybe we'll finally be over this, which would be my hope. Both Pfizer and BioNTech announced phase 2 and 3 trial data that shows the new boosters substantially increases BA4 and BA5 neutralizing antibody response above pre-booster levels based on blood samples taken 7 days after vaccination. So now we actually have some really good research data on looking at how things have played out over the last 2.5 years. This is the map I tend to show on every one of these webinars. And if you look at the moderate levels, which are yellow, you will see that the South is doing really well. Why is that important? Well, for the most part, when you're looking at disease states, you could look at something like the profession I'm in, the disease state I'm working with, HIV, much worse in the South. You look at sexually transmitted infections, much worse in the South. Basically, the South usually is the area that's hit hardest by disease states. And right now, the South is looking better than the Northeast. Is that because the weather has been warm until today and people are still doing a lot of things outside? That's possible. But we are doing really well with our moderate cases. In Georgia, we even have some low areas. And Georgia is traditionally not one of the states that does well with health outcomes. So it's a great time in the South, but if you look up at the Northeast, you have high community transmission, and that's something you need to pay attention to when we talk about the CDC guidelines and what should be implemented in your practice. So we're really looking at the community transmission levels, and later on in today's webinar, I'll show you how simple it is to find this, and you could put in your state. You could even look by county. So there are great levels, great information on the community transmission levels that are provided by the CDC now. When we look at the number of people who have completed primary vaccine series, so that is getting your 1 dose plus you completed your series. So you got 2 doses. As a total population, it was about 68%. A population greater than 5, 72%. You can look at the numbers along with me, and you can see the people who had the best completed primary series were those most at risk. Those 65 years of age and older, about 93% did get their primary series completed. So that's your first 2 shots. When you look at your first booster dose, the numbers of our country are less than 50%, and that is not good. And I've talked about we're lagging on where we are with our vaccination rates in the country. But again, if you look at getting your first booster dose, the people 65 years of age and older have done a really better job, but it's still not what it should be, about 71%. If you look at people over 18 years of age, it's just 52%. So this is just getting your first booster dose. Some of us, like me, have had our second booster dose. And if you look at that for a population of 50 years of older, only 39% have gotten that second booster. Population of 65 years and older, it's 46%. And the issue, I bring this up because if you look at where in Europe, we're having a problem with nursing homes and things of that sort. Our elder communities are at risk. So we really do need to focus on talking about vaccination, talking about the safety, and educating our patients and our colleagues and our friends on why it's important to stay up to date with your vaccinations. Nearly 3.3 million people in the U.S. received the updated COVID-19 booster shots over the past week. In total, the CDC said that 14.8 million Americans had received the shot as of October 12th, and the first weeks of the booster being available. Just 6.9% of people aged 12 and older who are eligible for the vaccine. So my concern is we do have this new bivalent vaccine. We know that BA4 and 5 are what's really driving this pandemic still in the United States. It's still what's driving the pandemic in Europe, but we're not seeing a great amount of uptake on this bivalent vaccine. As we're getting ready to move indoors for the winter, and we also are going to have to worry about a flu season as well, it's really important for us to get this bivalent booster. And to look at the science around it and how well it works as opposed to other means of trying to figure out should you or should you not get this. But regretfully, we're off to a slow start. That is not something that's new. We really have had a difficult time with vaccinations in the United States. By the end of last week, the Biden administration expected about 13 to 15 million people would get the updated shot, which is about 5 to 6% of Americans eligible. So we still have to work on it. I'm not surprised that this has been slow. I work in infectious diseases, so yes, my staff have gotten the bivalent. I'm scheduled to get it actually Friday morning. And so we're doing what we can because we want to protect ourselves, we want to protect our patients and our families. However, the COVID-19 booster shot is different. It's the first time a vaccine has been updated to match our circulating variants, and that's still the case. U.S. health officials have pushed it as a way to potentially reduce infections in addition to hospitalizations and death. So our previous vaccines did not prevent you from getting the disease. It just prevents you from getting really, really sick. So I was at a Georgia Board of Dentistry meeting, and some people weren't there. Some oral surgeons had a dinner the night before or 2 nights before, and they all ended up having COVID. So it's still there. It's still a reality, and let's not forget that. Among other metrics that the CDC tracks, the percentage of PCR tests that were positive for COVID increased compared to the previous week, with a 7-day positivity rate at almost 9%. We look at wastewater surveillance as what is happening and what we may see, and wastewater surveillance suggests that 35% of the country is reporting moderate to high SARS-CoV-2 levels. That is still a small percentage compared to where we have been in the past, when 80% of the country would have moderate to high levels of SARS-CoV-2. Again, it's a great time, a wonderful time to celebrate Halloween. The BA5 Omicron subvariant, which was first detected in South Africa earlier this year, spread rapidly through the world and became dominant, peaking in the United States in the middle of August. Since then, in both the U.S. and abroad, newer Omicron subvariants have been steadily gaining ground. But these subvariants still seem to react at this point to the bivalent vaccine. Some of the newer subvariants, though, do have mutations that allow them to evade earlier protection from infection or vaccination, adding uncertainty to how surges will evolve in the winter months. If we're uncertain how things are going to be, let's take the steps we can. Remember that Swiss cheese model. Take the steps we can on the personal responsibility side and on the community responsibility side, because our hospitals cannot stand another wave of a bad flu and COVID at the same time. And the latest variant proportion estimates that came out when I put this together, the CDC said BA5 slipped to almost 68%, while 3 others were gaining ground, and that includes BQ.1, BQ1.1, and BF7. BA4.6, which rose earlier this summer, especially in the southern parts of the Midwest, held relatively stable at 12%. And so what I wanted to do, sometimes all these words sort of blend. So I wanted to share with you this chart that has been coming out. And if you look on your chart on the far left, we had BA5 that was, you can see how it was sort of peaking when we got into August. And if you look at the far right, you can see that the BA percentage has dropped. It's about 68%. BA 4.6 with the light blue, you can see is about 12.2%. And then you can look at the variance based on color on the left-hand part of the screen and see that they're starting to increase. And so you're looking at the BQ 1.1, the BQ 0.1, and the BF 0.7, and there will be a test afterwards. Just kidding. But it's just to give you a visual on that the Omicron BA5 is still the most prevalent. It is dropping. Some of these new subvariants are gaining more ground. We know the vaccines will work against them at this point, but some of the monoclonal antibodies may not. And I think that's one of the concerns that we have. The U.S. public health emergency has been extended for another 90 days. It has been in effect since January 21, 2020. And we started this webinar series in March of 2020. So we have really, truly been on top of it. And I'm very grateful for Henry Schein and OSAP for giving me this opportunity over these last 2.5 years to share some of this information. The emergency has been renewed 11 times so far. Several response efforts hinge on the emergency declaration, which also allows the government more regulatory and funding flexibility. But as I said, what seems to happen in Europe then comes to the United States. So what are we seeing happening overseas? COVID activity, as I mentioned, COVID activity often precedes activity in other parts of the world, notably the United States. And the region is seeing widespread increases in activity, especially in people ages 65 and older, with 1/3 of the countries reporting rising deaths, according to the European Center for Disease Prevention and Control. Intensive care unit admissions continue to rise, and cases and deaths in nursing homes are increasing. Now, these are in Europe. The group forecast suggests the trend will continue for the next few weeks, and so far, there are no major changes in variant distribution. What's important about that is if we do get the bivalent booster, we are covered. So again, if you haven't got the booster at this point, we're getting a warning from overseas saying it's time to get the booster now. The FDA gave emergency use for authorization of the Pfizer-BioNTech updated booster for children ages 5 to 11. Moderna is ages 6 to 17. The vaccines are formulated with the original coronavirus strain and the Omicron subvariants BA4 and 5, which, if you remember from that chart, that's still causing the vast majority of cases in the United States, and from what I just said, as well as in Europe. These account for almost 80% of all of the coronavirus infections, according to our CDC. Despite the potential threat of a winter surge, primary two-shot vaccination rates in children are low. Only 31% of children aged 5 to 11 years have had the complete series. I did want to sort of switch away and talk a little bit about long COVID, because we're going to have patients who do have long COVID. And if they have symptoms such as shortness of breath, we might need to position them differently. We're also seeing an increased incidence in people who are presenting with diabetes. So doing a diabetes screening, if you have a CLIA waiver, is a great thing to help people discover whether they have diabetes or not. So there are tests out there. There's glucometers that you can use. There are hemoglobin A1C point of care tests that you can use. In the future, I would like to talk about how we can get a CLIA waiver, and you can start doing some of these tests in your office. Just because we also know how the negative impact uncontrolled diabetes does have on the oral cavity, and if we can get oral health under control, we can reduce inflammation and have better diabetes control. People with asymptomatic infections, however, are less likely to suffer long-term effects. And vaccination appears to offer some protection from long COVID, so that is important. So there have been some studies, and I'm going to talk about a few of them now. And one of the more well-conducted population-level studies shows that we should be extremely concerned about the current number of acute infections. Jim Pell, a professor of public health at the University of Glasgow, who led this research that's coming out of Scotland, emphasized that the study revealed wide-ranging impact of long COVID on people's lives. There are lots of different ways this impact is going beyond health to quality of life, employment, schooling, and the ability to look after oneself. The paper was published Wednesday in Nature Communication, represents the first findings of an ongoing study of long COVID, and there's the name of the study. It's COVID in Scotland study. We also have one in the United States that I'll be talking to again, because Kaiser tends to have some great information in their EMR system, and we can pull information from that. Previous studies have been challenged by nonspecific nature of long COVID symptoms, including breathlessness and fatigue, which are also common in the general population. The COVID in Scotland study, which included a control group, so people who didn't have COVID, was able to pinpoint which symptoms were linked to COVID and which ones were not. Those who had COVID were significantly more likely to get 24 of the 26 symptoms studied compared to the never infected general population. For example, those who infected were 3.5 times more likely to be breathless. If we have patients who are short of breath, we might have to have more breaks in providing dental care, more breaks when we're doing our preventive care, because we don't want our patients to panic if they're feeling breathless. So again, there's things that we can do to make our patients' visits safer and better for quality of life for those that we serve. Long hauler symptoms range widely from person to person. In the Scottish study, the most commonly reported symptom included breathlessness, palpitations, chest pain, and what we've heard about as brain fog or reduced mental acuity. Symptoms are worse among people who were sick enough to be hospitalized during the acute infection. Again, this helps you figure out. So if you had a patient who was hospitalized with COVID earlier on, they're much more likely to have some of these long COVID symptoms. And that's part of the medical history we can review with our patients when they come for our service. The study found that the risk of long COVID was greater among women, older people, and those who live in economically disadvantaged communities. People who already suffered from physical and mental health problems such as respiratory disease and depression were also more prone to long COVID. In the United States, the range of reported symptoms and inability to provide a prognosis for patients have been perplexing long COVID researchers, even as the breadth of the challenge has become clearer. Between 7 and 23 million Americans, including 1 million who can no longer work due to long COVID, are suffering from the long-term effects of infection with the virus. And that's from government resources. New research from physicians and researchers at Kaiser Permanente that I was just mentioning, the Mid-Atlantic Permanente Research Institute, and Johns Hopkins identified 17 conditions associated with long COVID in order to better diagnose and treat the conditions. The name of the study is the Post-Acute Sequelae of SARS-CoV-2 with clinical condition definitions and comparison in a matched cohort. This was recently published again in Nature Communications. The researchers looked at medical records at over 100,000 Kaiser Permanente Mid-Atlantic State adult patients, over 30,000 who tested positive for COVID-19, and over 70,000 who tested negative for COVID-19. It's always important when you're doing research, when possible, to have a control group, especially when you're looking at epidemiological studies such as this. The 17 conditions that were identified ranged from other lower respiratory or respiratory disease, diabetes, gastrointestinal disease, dizziness or vertigo, abdominal pain, nonspecific chest pain, mental health disorders, anxiety disorders, genitourinary symptoms, fatigue and malaise, which is one of the biggest ones that we're seeing, cardiac dysrhythmias, nervous system issues, respiratory failure, the loss of smell, nausea and vomiting, fluid and electrolyte disorders, nutritional, endocrine, and metabolic disorders. This is a wide range of conditions related to long COVID that are impacting people that we know, patients that we serve, and possibly even members of your staff who have had to deal with this. Researchers were most interested in conditions that developed in their patients within 30 days of a positive COVID-19 test and persisted for nearly 4 months post-test date, and conditions that developed in the 30 to 100-day window period after a positive test. Key conditions included loss of smell, like I mentioned earlier, cardiac dysrhythmias, diabetes, and I did bold that for a reason, genitourinary disorders, fatigue, and chest pain. These are things we really should know a little bit about. The researcher used Kaiser Permanente's electronic medical record to categorize conditions into 3 distinct time intervals based on when a patient tested positive for COVID-19. By organizing conditions by date when a patient tests positive, researchers were able to effectively evaluate if the resulting symptoms were related to long COVID as opposed to being caused by a pre-existing health condition. The advantages of having such a large electronic medical record. By comparing COVID-19 positive patients to COVID negative patients, researchers were able to tease out which symptoms appeared more often in the COVID positive group, which symptoms occurred more often in the COVID negative group, and which symptoms appeared at the same rate in both groups. Overall, 16.5% of COVID positive patients within the study developed at least one long COVID-related condition within 120 days of a positive test. This finding is lower than the national averages, which show nearly 20% of American adults who've had COVID-19 report as having long COVID symptoms after the acute infection. Researchers did find out that some patients may have developed diabetes after COVID-19 infection. Over 780 patients received a new diagnosis of diabetes between 30 and 120 days after a positive COVID-19 test. And this is by the researchers who've been doing this work. It's possible that some patients were simply undiagnosed till they sought care for COVID-19 infection. We know there are comorbidities that are making people more sick that end up in hospitals. So was this undiagnosed diabetes? And I want to point that out. How many patients are we seeing that have undiagnosed diabetes, which I think it's really important for us as a part of the primary care team. We can offer this simple test to patients on a point of care, but that does involve getting a CLIA waiver. It does involve setting up best lab practices. But again, this is something that you can buy a test. My dental assistant literally ordered a hemoglobin A1C test for me so I could start doing that in my program. Because we're, again, a part of the entire network of care for this patient population, and we do more than just make people smile and restore function and eliminate infection. APIC, which is the Association for Professionals in Infection Control and Epidemiology, is strongly urging its 15,000 members to uphold a mandatory mask requirement policy for healthcare employees in all patient care spaces. That includes dental offices. And that's where there's a little bit of a break between what APIC wants and what the CDC is saying allowable in our offices. And so I'm always conservative when it comes to prevention. In the building that I'm at, since my patients are immunocompromised, you can't walk in this building without having a mask on. At the hospital where I work, masking is still mandatory. When I go visit some of the physicians that I need to see for this problem or for that, again, they're masking people in the waiting rooms again, even though we're at this wonderful time of lower COVID rates. Why is masking so important? Because not only is it going to be important to prevent us getting COVID, it's going to be important for us to prevent getting the flu. So masking is just one step. Hand washing is another step. Cough etiquette is a third step. So there's so many different things that we can do. So we want to make sure that the recommendations came after a recent update from US CDC that advises healthcare facilities to use community transmission levels of COVID as a guide when source control through masking is necessary. But we want to mask in the healthcare setting a little bit differently because we are healthcare providers. So what did the updated infection control recommendations for healthcare personnel that were just released in September 23rd of 22? Updated to note that vaccination status is no longer used to inform source control, screening, testing, or post-exposure recommendations. Updated circumstances when use of source control is recommended. Updated circumstances when universal use of personal protective equipment should be considered. And I'm going to let you look at the rest, but I'm not going to read it to you. But I will say, what are we doing differently in my program today when we have moderate to lower levels of COVID in our communities, as opposed to what I did last January when we had this huge outbreak? And the answer is I'm doing nothing different. I am still, if you can wear a fit tested N95, and remember, you have to get an annual, according to OSHA, an annual fit test for your N95. We're wearing N95s for our patients. We're wearing our appropriate PPE. As I said in many previous presentations, there is an alternative if you can't wear an N95. I have one person on my staff who has severe asthma and has a difficult time working with the N95. She did get fit tested for it, like all of my staff, but she's allowed to wear a level 1 or 2 mask under her face shield. Makes it easier for her to breathe. So we are testing more frequently. We are looking at the different variants, but we are still using transmission-based precautions. Why? Because in dentistry, almost in everything we do, we create an aerosol. So we are doing the steps necessary to keep the patients and staff healthy. One of the most important changes is that much of what we do is determined by how much COVID is in our community. So if there's high rates of transmission in the community, CDC wants you to take extra precautions. CDC has recognized that between vaccination and immunity from people getting COVID, plus more effective treatments, less people are suffering from severe outcomes for COVID infection. But it's still severe enough that you basically feel like you have a flu. Because many patients are asymptomatic, and so many of our procedures, general splashing, spraying, splatter, and aerosol, we can still be exposed to COVID. And as of now, none of my staff, whether they're and they're over 20, whether they're in the dental clinic setting or at home, has developed COVID. And I'm very proud of that. They really followed their guidelines and have great quality of life, going to concerts, going to movies, enjoying life as they can right now, but also protecting themselves when need be. So how do you track your local community transmission levels? There is a CDC COVID tracker. I put a little screenshot of it here for you. You just look at CDC COVID tracker, and then you can go to COVID in your community, and you can either put your county or your state, and county level is fabulous. You can see how much COVID is in your community. And this is actually updated on a weekly basis. So again, that's what leads into your community transmission levels of the CDC. And you can see where the low levels are. There's some areas of Georgia. Looks like there's some areas of Southwest Texas, some parts of the middle parts of the country, some areas possibly that could, I don't know where Las Vegas is, but some low areas in Nevada. And you can see that there's some moderate levels in California, but they also have some substantial levels. So it really depends on where you look. And if you look closely at the map, if you went into New York State, it's not all high. Your county might be a moderate level. So it really gives you an idea of what the community transmission levels are in your community, and will help guide you through your clinic work and through your family efforts. It lets you know where this disease is at the time. But this is the best I have seen the map since we started doing these presentations a long time ago. When community transmission levels are not high, offices can choose not to have patients and or staff wear masks while in the office. So this is up to your decision. In my decisions, we are wearing masks all the time. The only time we don't wear masks is if we are in a non-clinic area. But if we are walking in the hallways, we're in an operatory, we're protected. When community transmission levels are high, both patients and staff should wear masks in the office. During those time periods, make sure you wear a mask for any face-to-face contact with the patient wear masks in any areas where you could contact patients, and you should wear one in staff-only areas as well as walking in the hallways. And I did want to thank Lanny Kay. She is our OSHA, I will say, goddess in Georgia. She's a lovely provider who actually keeps us up to date. And I thought she worded it in such a more understandable way than maybe some of the official documents. So I did want to thank Lanny for this information. PPE. Honestly, there have been no changes in my program, but this is what the CDC is saying. When working on screen patients who are not suspected of having COVID, because we still must screen our patients, and community levels are not high, we should follow standard precautions like we always have, which means you wear your gloves, a mask or respirator, eye protection, really important. And make sure your patients, while you're working on them, have eye protection, face shields, and gown or jacket. Respirators and face shields are always a good idea when generating aerosols through a procedure, but are not required in areas where there's lower community transmission. So you can make the decision based on your levels of transmission and how you would like to run your office. In communities with high transmission levels, and we are getting ready to enter winter, just a little note there, respirators should be used when performing procedures that generate aerosols, and we all know the different kinds of things that we do to generate aerosols. Respirators should also be considered for procedures that generate splashing, spraying, and splatter. Wear close-fitting eye protection and face shields and gowns and jackets that will be changed after use. So I'm still using my Aegis extraoral vacuum system. I still have my portable HEPA filtration in every room. And as you know from previous times, I even have a negative pressure room that we use if someone comes in and they have flu type symptoms or they are, have COVID type symptoms. I also have negative pressure in my soiled room, so that stuff goes outside and doesn't sit inside the clinic. I always like bringing up the Swiss cheese model because if you look at it, there's several things that are personal responsibilities and there are things that are shared responsibilities. And each layer has imperfections, but when we have multiple layers, we reduce our risk. So the first is physical distancing. We're not really doing that so much these days, but we have it set up in the waiting room for that. Stay home if sick, and that is a problem, especially with inflation going up and people not wanting to miss parts of their paycheck. It's really important if you have staff that are sick for them to stay home. And we've had issue with that here. Masks, wear masks when appropriate. These are something that are personal responsibilities to protect yourself and others. Hand hygiene. I was at a big leadership development meeting at my hospital and saw a surgeon cough into his hand. We cough into our elbow as a safer way of doing this. Avoid touching your face. And we touch our face, I can't tell you how many times per day. But those are things that we've done in the past that are personal responsibilities that you can take to help protect yourselves. Testing and tracing, that's a part of a shared responsibility. Ventilation or air filtration is really important, which is why I have those HEPA filtration units and those Aegis vac stations. Government messaging and financial support, quarantine and isolation when necessary, and then vaccines. And if you look, these virus particles, you have all these different barriers. It really is hard to finally get to the person or the provider, whether it's a dental assistant, a dental hygienist, your office manager, the dentist on staff, my residents. I've said this for a long time. My primary responsibility is the safety of my staff, my patients, and their families for doing what it is I can do to keep a healthy environment. So I'm going to switch a little bit. And again, I'm thanking Dr. Severance for reminding me to bring this up. But an update on monkeypox. New monkeypox cases have declined by 85% since the August peak. Why? Experts attribute the drop to a variety of factors. The monkeypox vaccine, which has an 85% efficacy rate, helps slow down the virus. Men who have sex with men reduce partners following the rise of cases in the wake of large gatherings around Pride. So what we did, not we, but the federal government did, There were pride activities in June. There were pride activities in October. There were some pride activities in August. And what you had were these massive efforts to vaccinate people who were at risk. So people changed and behaviors changed. As a virus spread by close skin-to-skin contact was self-limiting, unlike airborne coronavirus, finding fewer places to spread as potential hosts reduced exposure, and vaccine produced was effective. And here you can see a remarkable graph where you can see how bad it was in July, and then August it started to go down, and look where we are today. This was a combined effort of people being vaccinated, people changing behaviors, and we were able to get a very painful, because these were enormous. I'm not going to show you some of the oral slides that I have seen from patients here, but enormous ulcerations in the mouth, painful ulcerations in the genitourinary areas, painful ulcerations in the buttocks area. And so we got the fear part. It wasn't something people wanted to get. People were protecting each other. People were getting vaccinated. And when people work together, we can get this remarkable reduction in cases, something we have not yet seen with COVID because of political divisions. If we would take politics out of it and depend on science, I would love to see a curve like this in COVID in the near future. So another thing that I wanted to bring up, we've had the first occupational transmission of monkeypox from a patient to a provider. And this was in the CDC MMWR that was just released. The Florida Department of Health notified CDC of a nurse who acquired monkeypox through an occupational exposure while providing care to the patient. And basically what happened is she wanted to get a better sample, a better swab. So she used a needle, or he, I don't know the gender, he or she used a needle to basically pop the vesicle to get a better swab. But when she recapped the needle, she did it with two hands. And so she got a needle stick. So recapping needles, something we don't do. We recap them, but we have devices. We were very safe about it. Apparently, for some reason, this had occurred. I'm always concerned on our safety calls at the hospital on the number of needle sticks I hear about. And honestly, we try not to have them in our environments because of the post-exposure prophylaxis we'd have to do based on HIV. But what happened was she recapped, caused a break in the skin and the index finger through the gloved hand, accompanied by a small amount of bleeding. Just like you're supposed to do, immediately wash your hands with soap and water, and they drenched it with a betadine antiseptic solution. I'm not exactly sure what that would have benefited, but it is antimicrobial. It was reported to the county health department. Later that day, the lesion swab collected from the patient by the nurse tested positive for monkeypox virus using real-time PCR. Within 15 hours of the incident, the nurse, who had no relevant past experience, past medical history or previous monkeypox vaccination, received her first dose. So they did a post-exposure vaccination, which was literally giving her the vaccine after her exposure. She was not someone who was considered to be at risk before the exposure. 10 days after the exposure, a single skin lesion formed at the site of the needle stick. The nurse immediately began isolating at home and kept the lesion covered until it had crusted over, the scab had fallen off, and a new layer of skin had formed beneath the lesion 19 days later. So again, this is the first case of monkeypox infection resulting from an occupational exposure. Apart from the single lesion at the puncture site, no additional lesions or clinical signs or symptoms were reported. No secondary cases were identified. The report describes the first occupationally acquired monkeypox infection in the United States from a healthcare worker during the 2022 monkeypox outbreak. I always like to talk about in dentistry, since I work in HIV, how many documented cases do we have of a dental healthcare worker seroconverting after an exposure from HIV positive individual? and the number is 0. We've never had a documented case in dental. Means we should still use our post-exposure prophylaxis because we don't want to have the first. There was one lab person since 2000 who did have an occupational exposure working on concentrated blood and ended up seroconverting. So the goal is to not have any more of these. The goal is always to use safety precautions when dealing with monkeypox or any other infectious disease. So as always, thank you for the opportunity to share this information. If you have topics that you'd like us to talk about, please send them in. If you have questions, I'm sure Corinne and Blake will get those questions to me, and I'll be more than happy to answer. And as always, it's just a pleasure. So I'm going to turn it back to our host, Dr. Severance, for final words. And again, thank you for your time and attention.
Thank you, Dr. Reznik, for your continual updates. And thank you for watching. Please email us with any questions, concerns, or future topic ideas at webinars@henryschein.com. And please subscribe to our YouTube page by clicking the subscribe button below, and click the bell icon if you want to be notified of new premieres. With that, thank you once again for watching, and stay safe and stay informed.